Welcome to the lecture on Child Psychology Part 3. I am Dr. Fawaz Siddiqui from Department of Pediatric Dentistry. This lecture is the last lecture in the series of lecture on child psychology, and today we are going to conclude with some more theories and some more concepts on development of emotion and mental development in children. So the learning objectives are to describe the mental and emotional development. We're going to look at some few more aspects of those, and we're going to learn about fear, anxiety, and cry, which are part of the emotional development in a child. So you need to describe and discuss these factors, which you will be able to do at the end of this session. A quick recap of what we learned in the last session on child psychology, which was child psychology 2. In that session, we had learned about the psychosocial theory given by Dr. Erik Erikson, and we also learned the theory of cognitive development given by Dr. Jean Piaget. The theory of psychosocial development was on the development of the personality of the child. It was divided into 8 stages from infancy to old age, and how the development of personality occurs through different phases, where you have the crisis, and then if the crisis is resolved, something happens, and if the crisis is not resolved, something else happens which influences the personality of the person. In the theory of cognitive development, we looked at how the mental process of humans develop. How do people start thinking, and the concrete thinking and the abstract thinking, at what age the concrete thinking is there and at what age abstract thinking starts, so which helps us to understand what kind of messages the children can understand and what kind of things that they can perceive, understand, and respond to. So these were the two theories we touched upon the last time. Today we're going to deal with a part of Dr. Sigmund Freud's theory on psychosexual theory. We are not going to look into the detail of the psychosexual theory, but we are going to look at the basic fundamentals of a human mind as given by Dr. Sigmund Freud in 1905. So Sigmund Freud basically described the human mind. Don't confuse it with the brain. Brain is the anatomic structure, but human mind is more on the abstract level. So Dr. Sigmund Freud tried to explain the human mind, and he used two models. One is the topographic model, and the other is the psychic model, to explain how it happens. So topographic model was what he uh, explained, and then he improved on the model and he came out with the psychic model, and both the models are still relevant in present times. So we need to understand these two models to understand how the human mind works. So in the topographic model, we have 3 levels. We have the conscious level, we have the pre-conscious level, and then we have the unconscious level. And what you see in the picture here is called as the iceberg phenomenon of or the topographic model of human mind, explained through an iceberg, where this is the level of the water. So what you see outside the water is the tip of the iceberg, and what you see inside is what is not visible to the eye. So basically what is seen is the conscious level, but what remains deep into the mind is the unconscious level, which is quite huge. So let's see what are the significance of conscious level. So conscious level, or the conscious mind, or the conscious mind system, is your current state of being. That means you are aware of things around you at a particular moment of time. So when you are sitting here and listening to this presentation, you are aware of the presentation occurring, but you're also aware of the color of the wall behind you, the numbers of the door in your room, the number of windows in the room, okay, people who are outside your room. So you're also aware of these things. So conscious level is made up of your thoughts and your perceptions. So this is happening at present in a particular point of time. So this is what we call as conscious mind. So you are aware, you are conscious of your thoughts and your surrounding. So this is the conscious mind. Then, and the next level is the pre-conscious mind. A pre-conscious mind stores the information which passes through the conscious mind. Okay, so pre-conscious mind is the storage of information which is part of the conscious mind. So all that you saw, heard consciously is stored in the pre-conscious mind, and this information can be retrieved easily. So if you have met somebody a couple of times and shook his hand and spoke to him, and if you want, if you forget to recall the name, maybe if you stress your memory a bit, the name will come back to you. So this is the pre-conscious mind. So you are aware of your surroundings and you're aware of your perceptions, and these all are stored in pre-conscious mind. And deeper in the mind is your unconscious mind, also called as subconscious mind, and it is here the information is stored, all those informations which was part of which was not part of your conscious mind. Okay, so a typical example is when you are walking into a supermarket, right? There are so many things happening around you when you enter a supermarket, right? But what you are looking at when you're entering the supermarket is the door opens and you walk in, and maybe somebody is fighting in the corner, so your attention goes to the people who are fighting. But at the same time, there's so many people walking around you, right? So many people walk past you. You see the color of the wall, you see some product which was kept in a place which was not there before. So all this the mind captures and stores as data in the subconscious level. All right, and this is also can be explained by deja vu, right? Where you remember seeing somebody, right? But you cannot recall when it was, but you remember seeing that person, and you're like, we have met, but I don't know where we have met. What's your name? And even after the name, you cannot, but the face is so familiar. So this is your subconscious mind at work, and it is here in the subconscious mind that you have lot of uh, thoughts which are not under your control. All right, so this is all deep buried in your mind, which is called as the subconscious mind. So if you see in the iceberg, you have these fears, unacceptable sexual desires, irrational wishes, shameful experience, selfish needs. They're all in the subconscious mind, right? And there may be some circumstances where you act in response to a situation from the knowledge based on your subconscious mind. All right, and then you're like, oh my god, why did I do this? So this is the part of the subconscious mind. So it's a much bigger part of your mind, and it stores all that data which has not happened in your conscious state of mind. So this is a really a big part of your mind. So this is the topographic model of mind, and let's see the other model. The other model is the psychic model of mind, and in this model there are three basic uh, factors. As you can see in the table, you have your id, then you have your ego, and then you have your superego. So superego. So here the mind develops in one way direction, which is this way. First you develop id, which is occurs at birth, then you develop an ego about when the child is 2 years of age, and then you develop superego when the child is about 5 years of age. So let's see what happens during this development of mind, or during this in this model of mind. So basically, when the child is born, all that he knows is something called as the pleasure principle, which means that the child needs immediate gratification. So what happens is, if the child is hungry, he will cry, and he will cry till the time he gets his milk. Okay, so this is something called as immediate gratification. So this can happen, this begins at birth, but it can happen later in life when a child comes to your clinic and he wants to do something, right? And he wants to do it now, and he will not listen to anything, and he just wants to do his thing. So this is the principle of pleasure. So which says that the child will want immediate gratification. So this gratification, the thinking process is that the child forms a mental image of the desired object. Okay, so the child develops this image that I want this, and then he persists with an impulsive behavior or an uncontrolled behavior to achieve the gratification. Okay, so this is the id. So id normally develops in birth, but you can also see id later on in life also. So if a person is developing normally, so he will have this id at birth. So from birth till 2 years of age, he will have this pleasure of principles. He wants something, he wants something. He will throw tantrums, he will want to have it. Then develops the ego. So ego is based on the principle of reality, okay, where the mind will weigh the cost and benefit of an action before deciding to take an action. So here the mind will give a thought, should I do it or should I not do it? What are the pros? What are the cons? Okay, and this can lead to two things. One is the immediate gratification, okay, but this immediate gratification will happen with something which matches the mental image created by the id. So maybe it's not the exact same thing, but a substitute, but they will try to get the gratification done. Or you can have a delayed gratification. That means the ego will eventually allow the behavior, but only at the appropriate time and place. So ego basically tries to manage the id. It does not let the id go out of control, and therefore it has to balance the id. Then if the child develops and the mind has develops further, the child begins to develop something called as superego, which begins at the age of 5. It can begin earlier, it can begin later in life, but in most of the children it begins at 5. Here you have two principles. One is the ego ideal. So ego ideal is where the child sets some rules and standards for self behavior. Okay, so he says, I will not do this because it is below my standard, or this is not who I am. And the child also develops conscience. Conscience means he understands the moral standards of the society. So the society says this is a taboo, it is banned, the child will not do it, even though the child may have an id for it. So the child may want something very badly, all right, but the ego will come into the picture and he will say, wait, let me think about it, let me weigh the pros and the cons. And the super ego will say, wait, this thing that you want to do does not satisfy my standards or does not satisfy the moral standard of the society, so we must not do. Okay, so what we have here is something called as a secondary thinking, and secondary thinking uses the ego ideal and the conscience to satisfy the id, which may not be possible every time. So superego will stop the child from doing so many things, and ultimately what it tries is to suppress all acceptable urges of the id, unacceptable urges of the id, and it struggles to make the ego act upon idealistic standards rather than upon realistic standards. So here the person is more moralistic and more judgmental. A typical example that I want to give you of this psychic model that happens in present life, in adolescence, in adults is, say for example, you go to a vending machine and then you put in your money, all right, and you order the drink, you press the buttons and the drink comes out, and then there are some changes which falls into the change box. And when you put your hand into to collect your change from the change box, and when you retrieve, you find there are more changes than expected. So that means you're expecting 20 cents back, but suddenly you find there are 70 cents in your hand. So that means somebody has forgot to pick their change when they ordered the drink. So your id will come into the picture and your id will tell you, keep the extra money. Okay, we will spend it on something nice. So your id will tell us, okay, pleasure principle, let's spend it on something nice. Then your ego comes into the picture. The ego will say, should we spend it? On what should we spend it? Should we spend it immediately? Or should we not spend it immediately? What shall we do with this the best? Should we spend it on something to eat or something to buy? But then the superego comes in. The superego says, look, I'm not a thief. I'm not going to take this extra money. This is not my money. And the conscience will kick in. The conscience will say, the society does not allow such kind of behavior. Okay, dishonesty is unacceptable in this society. So what I'm going to do is I'm going to suppress my id, which is telling us to use the money, and what the superego will tell, leave the coin where you found it, or go give this coin into the charity, because that is the right thing to do. So this is an idealistic standard, okay, of superego. So this id, ego, superego happens so many times. Another example I want to give you is when you're sitting in the exam and there is a question that you don't know the answer to, okay, and you suddenly see that the person sitting in front of you, his answer sheet is open, and the question that you cannot answer, you can see the answer in his answer sheet. So the id will tell you to copy the answer so that you get good marks, right? Your super ego will come into the picture, and super ego will say, okay, I will copy the answer, but I need to wait till the invigilator is not looking at this side, or maybe he's walking away, or when he has his back on me, so I can copy at that time. So your ego is making this realistic plan to satisfy the ego, satisfy the id. Then your super ego will kick in. The super ego will say, no, I will not cheat because I'm not a cheater. This is below my standard. And your conscience will tell you, no, this exam is conducted fairly. Everybody should get a fair chance. So cheating, I should not do cheating because everybody has to be fair in this exam. So what ultimately happens is maybe sometime the super ego will dominate and you'll do the right thing, or sometimes the id will dominate and then you will use the ego for immediate gratification or delayed gratification. So this thing happens very, very often in adult life also and in children also. So Sigmund Freud used these techniques to explain the model of mind. So this slide basically tells you how topographic model and psychic model are merged together, how they look like. So if you look at the iceberg, and if I ask you what part of psychic model, okay, is represented by the unconscious level of the human mind. So I'm asking you what part of psychic model is represented by the unconscious level of the human mind. So if you see, the id is the part of, full id is part of the unconscious level. So you must understand that your id is basically coming from your unconscious level, your basic impulses for aggression, for sex, for seeking immediate gratification, and this can be an irrational or impulsive behavior, and this operates at the unconscious level. So a lot of times you will see people do something automatically out of compulsion, and this is where they have this id which is controlled at the unconscious level. So this iceberg tells you the overlap of topographic and psychic model. So with this understanding of how the mind is mapped out, we now try to understand the emotional development. So when we talk about the emotional development, we have looked at the emotional development or the personality development by Erik Erikson, but here we're going to discuss some factors which are related to emotional development, something like emotions, distress or cry, anger, fear, anxiety, and phobia. So these are some of the emotional responses that you will see the children exhibiting, and you must understand these emotions and why this happens and what you can do about it. Okay, so let's see what is emotion. So emotion is state of mental excitation, okay, characterized by physiological and behavioral changes and alteration of feeling. So you have this physiological changes of your adrenaline pumping, and then you have this fight or flight response, and because the excitation is there, and there will be some behavioral changes, maybe you get aggressive, and there will be some alteration of feeling like happiness or sadness. So this is what is basically an emotion, physiological, behavioral, and alteration of feeling. So this emotion can be expressed through bodily movement. So you're happy, you jump around, all right, or your facial expression, you smile and you laugh, or it could be vocalization. That means you are like shouting hip hip hooray, awesome, excellent. So you try to express emotions, or you cry, which is kind of an expression of emotion. So these are the ways that the child or even the adult can express their emotions. And some of the emotions that we will discuss is the distress, anger, fear, and anxiety, which are very common in dental practice. So let's talk about cry. All right, so cry is like the basic foundation or the primary emotion. So what cry is the basic emotion that God gave you at birth. All right, so we are talking about the development. So at birth, the primary is the only emotion. So what the children do at birth, when they are born, they should cry. And any child who doesn't cry when he is born, right, something is wrong, and the child is made to cry. So if the child cries, it's okay. The child is crying, that means the child can breathe. So everything is okay. So this is how it happens. So this is a primary emotion, or the first emotion that you are born with is the cry. So by the age of 6 months, the crying becomes lesser and lesser, and it is more related to the needs, like, I'm hungry, so the child cries, so the child is fed, and then the child stops crying. Or the child has soiled his diapers and he cries because of the discomfort, and the diaper is changed, the child stops crying. So this happens at about 6 months of age. So when the child goes into the preschool, okay, the crying still further lessens, and it is more related to physical pain. So the child falls down, he cries. A child hurts himself with something, he cries. So crying is more related to physical pain. And when the child progresses to school years, maybe around 6 to 12 years, the crying stops or seldom happens, and mainly because of pressure of not crying. So you're crying like a baby. Are you a baby? So certainly this certain pressure is there that even if I'm having some physical pain or some discomfort, I should not cry. So this is the part where the children start to control their cry. And of course in the adult, you rarely see adult crying, and if you see, then definitely it is related to some intense grief or intense feeling of maybe happiness or sadness or sorrow. So you will see adults crying. So this is how the crying develops over the ages. And when we are talking about crying, it is important for us to recognize the type of cry. And if we are able to recognize the type of the cry, we can take appropriate steps to ensure the crying stops. So we have to learn about the types of crying. So what you see here is the types of cry. So there are 4: obstinate, frightened, hurt, and compensatory. So this is normally you see in children in the Department of Pediatric Dentistry. So let's see each of them, what they mean. Okay, so this table basically gives you a very good bird's view of the different types of cry, as differentiated by the type of sound the cry is made in, the situation the cry is made in, and the tears that you see in the particular cry. So let's start with the first one, is the obstinate cry. So this obstinate cry is mainly loud, high-pitched, siren-like cry. So the child is really crying, and you have to put your hands on your ears to dampen the cry. So the child is crying, and this crying is basically the child's response to anxiety. So the child is feeling anxious about something, and he cannot vent it out, so he gives a loud cry, and this is also called as temper tantrum. So the child is crying aloud and having bodily movements, and he's just not ready to listen to anything, and this is the temper tantrum. So you have this obstinate cry. So most of the time this obstinate cry you will see in a supermarket if the mother is not buying the toy the child wants. So the child throws a temper tantrum and he's rolling on the floor, crying and kicking his legs. So this is called as this loud high-pitched crying. So the child is trying to attract attention, so that his anxiety, somebody looks into his anxiety and removes the anxiety. The next one is your frightened cry. Now this cry is the sound is like breath-catching sobs. So it's basically something like this. Okay, so these are breath-catching sobs, and this happens because of child's response to an overwhelming situation. So now the child was anxious and he does not want to enter the situation, so he may give an obstinate cry. But if a child who enters into a situation and the situation is too much for the child to handle, then he will feel scared, he will feel frightened of the situation, and then he will have this frightened cry with breath-catching sobs, and then you will have a lot of tears associated with this crying. So if you see a child who's crying endlessly with lot of tears, right, with this breath-catching sobs, understand the child is frightened because of something, and then you need to look at what is the child frightened about, so that you can get the child to calm down. So this is the frightened cry. The third cry is the hurt cry. The hurt cry can be loud or it can be a small whimper. All right, and this happens particularly when the child is in pain. And how do you recognize this? You will see the child has a single tear which fills up the corner of the eye and then rolls down the cheek. And during this process, the child does not move. Maybe he makes a small whimper sound. So these are the childs who are very well behaved and they will try to cooperate with you till the end. And if something is hurting them, he will not ask you to stop it, but they will silently cry, and this is the hurt cry. So if you find that there is a tear filling up in the corner of the eye of the child and it's rolling down the cheek, it is the hurt cry. All right. So the last one is called as the compensatory cry. So this compensatory cry is a slow monotone cry, something like this. And this type of cry, that is the monotone cry, is the same tone. Okay, and this is the child's coping mechanism to drown out an unpleasant auditory stimulus. So the child does not like the sound of your handpiece, so he may give this slow monotone cry to drown out the unpleasant auditory stimulus of your handpiece. And the important thing is that there will be no tears, so that you will understand, okay, this is a compensatory cry. The child is just trying to cope up with the sound. So you really, do not need to do anything except you can complete the procedure with good behavior management techniques, so the child can overcome this kind of cry. So these are the 4 kinds of the cry, and what you need to understand is to recognize this cry. So next time you are in the pediatric dentistry clinic and a child is crying, right, try to differentiate the try to identify the type of the cry the child is having. So if you are able to identify it correctly, you will take your behavior management skills appropriately and the child will calm down. So this is very important, and therefore we are learning this before we learn about the behavior management technique. So you must be able to differentiate between these 4 kinds of cry. This can be controlled by identifying the particular situation and then teaching skills and attitude to handle the situation. So this is what we use in anger management class in adults, and then we ask the adults to talk about the situation in which they felt angry, and then they will learn some coping mechanism, some skills, some attitudes to handle those particular situation, and then they will stop getting angry. So this is what you need to do, at least identify the situation in which the child gets angry so that you don't present the same situation to the child again. Now what does the child do when the child is angry? How does he express his anger? By these ways. Either he will start throwing things, or he will try to hurt you, okay, either physically, or maybe the child is older, maybe try to hurt you emotionally, or he will neglect a task given to him, or he will withdraw from friends and family, or he will verbally abuse, or he will increase the tone of his voice as an expression of anger. So you will see all these happening in children and in the adults as well. So when you know, a typical example I give is that if you are angry with your mom, okay, and she's asking you to do something and you don't want to do it, and she's pressing you and pushing you and you get angry, what do? You neglect the task, okay, you don't do what she was asking you to do, correct? Or what you do is you go silently into your room and close the door and sit in the room till your mom comes and talks things out with you. So this is very common expressions of anger. So if the child is behaving in one of these ways, you understand that the child is angry with something, and then you identify the situation and then you can calm down the patient. So this is about anger. All right, so next one is the fear. All right, now the fear is the reaction. The fear is the reaction to a known danger. That means the known danger, that something bad is going to happen, something really messy is going to happen, and it's a realistic threat to one's experience. So if you find that something is going to hurt you, you will have fear. Okay, that is why you have fear of lions. Do you have fear of lions? Yes, I have fear of lions because I know if I go to a lion, he will eat me up. So there is immediate danger to my life. so I feel scared. So this is what is meant by known danger or a realistic threat. And this is basically a protective mechanism inbuilt in the body to protect the human body. Okay, but if this goes out of hand, then we have a problem. Okay, so now let's see how this fear, the different types of fear, so that we understand how to manage it. So first one is the innate fear. Innate fear is fear arising without any current or previous stimuli or experience. So basically you have not faced the situation ever before in your life, and it's just something inside you, that your sixth sense is telling you something is bad going to happen. Okay, and then you do not act, or you do not react, or you do something. So this is an innate fear, it's inbuilt. All right, and this is depends on the person's personality or vulnerability of the situation. So if normally people have fear of trying something new, so they have not tried it ever before, and there are people, people are telling you to try it and see once, and you're feeling scared. You have never tried it, and you have not met anybody who has tried it, but still you feel scared to try something new. So this is your innate fear, and it is inbuilt into the mind, and this is God's protective mechanism. So if everything fails, your innate fear will protect you. Okay, so the next type of fear is your objective fear. So in objective fear, the fear is acquired through direct stimulation of your sense organ and by a unpleasant experience the child has personally. So the child has to personally experience something unpleasant through the 5 sense organs: touch, hear, see, feel, and the experience has to be personal, and then the child develops this objective fear. So this objective fear or this unpleasant experience can be due to a traumatic dental experience. So child comes to you with a very bad experience from the previous dentist, and he will show objective fear towards dentistry. Or the child is given pain by people in white apron, so he sees you in white apron, they will have an objective fear that you are going to do something bad to them, which will give them pain or which will hurt them. Even children have objective fear of places which smell like hospitals or which look like hospitals, because they know that in such a place something bad happens to me or I get pain. So they have this objective fear of hospitals or clinics. Or even the medicines. The child will see that the mom is pouring a medicine for him, and then he will immediately fear the bitter taste, and then he will try to run away because he doesn't want to face the fear. So this is objective fear. So this experiencing is believing. So for objective fear, you must experience the situation. Similarly, the last one is the subjective fear, and this fear is acquired through opinion and feelings of others, okay, about an unpleasant experience where the child has not experienced personally. So the child has just heard people talk about it, and then he develops this subjective fear. He's not experienced it, but so many people talk to him about it, or he sees so many things that he develops this fear. So this fear can be subjective, like told by the others, or it could be imitative, looking at the others, or it could be totally imaginative. So subjective is when the child is going to the dentist and the elder sibling tells the child, oh, you're going to go there, you are going to get an injection which is so painful, or you're going to go there, oh, the doctor is going to pull out your teeth and you'll have a lot of pain. So this is a subjective fear caused by the opinion of the sibling. So this is suggestive pain. You can also have this imitative pain. So child sees somebody, okay, who is in an unpleasant situation, and the person cries or he shows some distress in the situation. The child learns that, okay, in this particular situation, somebody I saw who felt very uncomfortable, so he will get scared or he will have fear of this particular situation. So typically what happens is that if the child sees that the mom's tooth is being extracted and the mom is having pain and she's crying and she's very uncomfortable, the child will understand that this whole procedure of having the tooth removed is very painful, because my mom is crying and she's feeling uncomfortable and she's complaining, the child will try to imitate the same fear when he is faced with a situation where his tooth has to be extracted. So this is imitative, looking at others. And then one is imaginative. So the child will imagine that so and so thing can happen, and then he feels scared. Something like going into the dark. So the child will imagine that, oh, going to the dark, there are ghosts in the dark, so he will be scared of darkness because of the fear that the ghost will get him. So this is imaginative fear. So the sources basically come in from family, peers, or even TV or newspaper or any pictures in the magazine which give out a very bad impression of dentistry. Okay, the child will get this kind of subjective fear. So these are the kind of fear that child may have. All right, and then if you need to identify, and then you need to put a stop to it. So for a subjective fear, you have to tell the parent that don't talk about dentistry to the child. Let the child come to me and I will handle him in the clinic. So don't tell him he's gonna get an extraction, or he's gonna get his tooth filling done, or he's something is that. Just tell the child we're going to the clinic to have your tooth counted, and the doctor will count your tooth. So this will put an end to the subjective fear. For objective fear, we need to identify what is the particular experience the child is having fear, and then we need to replace it and substitute it with something else. You cannot do anything for the innate fear. All you need to do is try to build the confidence in the child through communication and helping them cope up to complete a procedure. So need to go back. Yeah. The third one is lack of control over the procedure. So if the child will think that he's not having the control over the situation, they will feel fearful of the situation. So if they want to have a restoration done, they will feel very fearful of not having control over the situation. So they are not taken into the equation of the procedure. So they will have this fear of that particular situation. So what you need to tell the child is you have to give some control to the child. So typically you have seen in the clinic, so we tell the child, if this becomes uncomfortable, raise your hand and we will stop. Okay, or we normally ask the child that if you are feeling comfortable, give me a thumbs up sign. So the child feels in control of the situation, and then he is okay. There is no fear that about the procedure. Then you have the fear of unknown. The fear of unknown, like me and you will have when you enter a new situation, you always have this fear of uncertainty of what will happen, what is going to be there. So the child will have this fear of unknown. And the last one is the fear of intrusion. So intrusion into your body. Okay, so sometimes the children will have this fear of something being done to the body, and then they will feel scared. So these are the different causes of fear in dental office in children, and the same can apply to adults also. So our objective is to identify and then do something about it. So the three most common fear evoking procedure in dentistry is LA because of the injection, extraction because it will be a very uncomfortable, unpleasant experience, or the sound of the drill because the drill itself will cause some kind of pain when you are working close to the pulp, and the child will get scared of the sound of the drill. Now because the child will understand, or the sound of the drill is coming, next the pain will come. So these are the most fear evoking procedures. So how does the child respond to the fear? So the child can respond at three levels. Okay, those three levels are at intellectual level, at emotional level, or at hedonic level. So what happens in the intellectual level is the child is ready to accept the fear evoking situation, and he faces the difficulty to achieve the desired results and the benefits. And this is usually seen in older children. So the child will try to suppress the fear in order to complete the procedure. So this is the intellectual level. Or you can have an emotional level. So the child shows fight or flight response immediately, right? And this is seen in school age. So when the child gets the impression that I'm going to have my tooth extracted, he will get up from the chair and run away. He will try to get off the chair, okay, and exit the cubicle, exit the clinic. So this is almost instantaneously, immediately. So the child is not thinking any, he just wants to get away. So this is the response to fear on an emotional level, and this is what you see in school children. 6 years to 12 years where they understand definitely something bad is going to happen, and then they have this emotional level. In even younger children, you have this hedonic level. Here, the child is ready to accept what is pleasant and he rejects what is unpleasant without too much concern about the outcome or nature of the procedure. Okay, so he takes what he likes and he rejects what he does not like. Okay, simple and plain. Okay, black and white. So this kind of response to fear the child will have when they are very young. Between maybe 3 to 5 years, they will have this response because they have still not developed the sense that something bad is going to happen. So they like it, they will agree to it. If they don't like it, they will immediately reject it. And how much ever explanation you give, the child is not ready to listen. He is not ready to accept. He doesn't want it. That means he doesn't want it. So this is the hedonic level of response to a fear. So typically it happens with your dental drill. So if he's scared or he's fearful of the drill, he will just close his mouth and he will not open his mouth. However, you tell the child, I'll do it slowly, I will do it nicely, I will do it this way, I'll do it that way. No, the child will not open the mouth. Then you tell the child, okay, I'm not going to use it. I'm going to use a spoon excavator. Okay, then the child will give it a thought and he will look at the spoon excavator. That spoon excavator will look like a non-invasive instrument, and then he will say, okay, spoon excavator is fine. So this is, the child is in the hedonic level. So this can happen between 3 to 5 years of age when the child is relatively young. So how do you manage fear is, first and the foremost, don't ridicule the patient. All right, don't make fun of the patient. Oh, you're scared of such this things, this is so painless, see, nothing is happening, you're just a fool to get worried about this. Don't ridicule. Okay, next is you identify the cause, and then either you remove the cause or you modify the cause. The example that I gave you is, if you're doing caries excavation and the child is showing hedonic level of response to fear of the dental drill, you go to caries excavation with your spoon excavator, modify, and then you're able to do some excavation, you're able to build some trust, and the child will start to change from hedonic level to more intellectual level of response to fear. So this is what you need to do for fear. Then we come to anxiety. All right, now anxiety is different from fear. It's in the definition. Anxiety is an unpleasant feeling of an impending doom or danger, okay, from within. That means from inside the body rather than from the external environment. So basically you are just thinking. The fear is coming from your mind. Okay, maybe there is not a real threat, but your mind is thinking that something bad is going to happen, and actually there is nothing in the external environment. So anxiety, typical example that I give you is when you want to go and sit for the exam. All right, so you are thinking that I'm going to fail the exam. What am I going to do when I fail the exam? Okay, so you have not even taken the exam, and then you have this anxiety over the exam, and this anxiety is coming from inside you because you have not even appeared for the exam. So you appear for the exam and you find the question paper was easy and you pass the exam, and then you will think, okay, pediatric dentistry is okay. You will not have anxiety to appear for another exam for pediatric dentistry. So this is your anxiety. So basically anxiety is a learned process which develops after appearance of fear. So if you have taken up exam and you failed the exam, you have this fear of that exam. So when you are going to appear for the similar exam, you will have anxiety that you are going to fail again even though you have not appeared for the exam. So this is anxiety. So it basically depends on your ability to imagine. So the worst you can imagine, the more anxiety you will have. In children, the causes of anxiety is basically uncertainty, previous experience by self or the others, or innate biological differences. So the boys are more brave than the girls, and the girls are more brave than the boys. Always the war is going on. So but there are some innate biological differences which cannot be really explained. But your attention should be here at maternal anxiety. So if the mother herself is having anxiety over the dental visit, the child will sense the anxiety and then he will have this imitative fear of something bad is going to happen, and the child will feel anxious that impending doom or there is a danger, and this is only arising in the mind of the child. So maybe the child is coming for the first visit, he doesn't know that we're going to examine the child and take a few radiographs and do some topical fluoride and leave the child in the first visit. So basically there's no pain involved. So but the child does not understand this. So we'll have this anxiety towards the first dental visit of what is going to happen. So this is basically anxiety. So there are a lot of types of anxiety. We are not going to go into the details, but I want you to look at all these different disorders of anxiety, and the child may exhibit some form of this disorder, maybe temporarily or maybe momentary. So you must understand that this is anxiety. The child is feeling anxious about some situation. Okay, so maybe the situation can be a separation from the parents. The child will feel anxious, or maybe there is a social anxiety where the child needs to participate or interact with other peers or other patients in the clinic. So they will have this social anxiety. So these are different kinds of anxiety that we must be aware of or accustomed to. So this brings us to the last part, which is the phobia. All right, so we looked at fear, we looked at anxiety. The fear was the response to a realistic threat to life, while anxiety was an impending danger. Okay, and the thought is coming from the self, so it is not realistic. And then you have phobia. So phobia is an irrational fear resulting from a conscious avoidance of a specific feared object, activity, or situation. Okay, so when I was young, I had this phobia of touching something which is furry. Okay, furs would make me, eeks and cring. So I had this fear of furs, and this was an irrational fear. Okay, so how do I say that this is not fear, this is a phobia? So you have to look at the criteria for something to be a phobia. So criteria number one, fear out of proportion to the stimulus of the situation. So my fear of furry objects having fur, okay, it is out of the proportion. The object is not going to hurt me, but still I'm feeling fearful, and the fear is quite high. So the fear is out of the proportion to the stimulus or the situation. Then the fear cannot be reasoned. I cannot tell you why I'm scared of furry objects. I just cannot tell you. I'm just having this phobia. I cannot reason why I'm not having it. And then when I am faced with my phobia, there is an involuntary, involuntary control. What basically says is being out of voluntary control. So people who have this phobia of cockroaches, all right, and you suddenly tell them, see, there's a cockroach near your leg, and they will automatically jump or climb on the chair. Okay, so this is your involuntary reaction that you have in phobia. So if you have all this, that means you are having a phobia to a particular situation. So if you read the literature, there are phobia of closed spaces, claustrophobia. You have phobia of spiders, onychophobia. But you will be surprised that there is actually a phobia called as trypanophobia, which is fear of medical procedures involving injections and hypodermic needles. So anybody who is needle phobic is basically having trypanophobia. So this is real. So if anybody is showing phobia to needles, when you talk about needles and they express these three criteria, you understand that they are having the phobia of the needle, and no amount of counseling can remove that phobia. So you basically have to go to a psychologist, have some therapy session so that the phobia can reduce. Okay, and something we also have in dentistry which is called as systemic desensitization. This you will learn when you learn about behavior management techniques. So we talk about how to deal with such kind of phobias in the clinic. You also have phobia of needles, then you have phobias of doctors, iatrophobia. So this is also very much true. People have fear of doctors. This does not end here. You will be surprised when I show you the next slide. Next slide is fear of dentist. Dentophobia or odontophobia. This is also very much real. People have fear of dentists and they do not go to the dentist for the regular checkup. They do not go to the dentist because of the fear of the dentist, and they keep on taking painkillers for their pain until the pain becomes an infection, and infection becomes a life-threatening situation, and then they go to the dentist. So these are the people who have got this odontophobia. So why do people have the fear of dentist? Okay, or even can happen with children, can happen with adults. So let's understand the concept why people have fear of dentist. So dentists themselves, the people may fear the profession as cold, unfeeling, or sadistic. So maybe dentistry is one surgical field, surgical specialty where you work under the local anesthesia. So the patient is basically wide awake and conscious, and everything that you say, do, your facial expression, everything is captured by the patient's eyes. So some patients may feel that the dentist was really cold, uncompassionate, with no feeling, and when he extracted the tooth, he felt so happy, really sadistic, he gave me so much pain and he felt happy about it. So these people will have this fear of the dentist, the fear of the profession itself. Then they will have this fear of pain. Some people will be very sensitive to pain and they will perceive some dental procedures as very uncomfortable or very painful, and then they have this fear of pain and they will not go to the dentist. Then you have this fear of numbness or gagging. There are some people you must have seen in your clinics who have extensive gag reflex, or they have difficulty in breathing when you put them in a supine position on the chair, and they will always tell you that, doctor, don't put the chair back so much, can you please upright the chair, I cannot breathe. So these are the people who have got this difficulty in breathing. So they are afraid that they might not be able to breathe or swallow after the numbness kicks in. Okay, especially when you're giving a local anesthesia where the half of the tongue is numb, they will have this fear that they will not be able to breathe or swallow, or they cannot hold water in the mouth in the supine position. So you're doing scaling and the child cannot hold the water into the mouth because he's having this difficulty in breathing in supine position. So this is another cause of fear of dentist or fear of dentistry. Then you have this fear of sound and smell. So people with bad dental experience, they recognize the sound, the smell around the dentist office, which cause them a bad experience, and then they will fear of that particular situation. So it could be smell of eugenol, it could be smell or sound of dental drills, which makes them upset or anxious or fearful. Then lastly, we have this fear of needles. Okay, so people who have got this fear of needles, this phobia of people, will be very extremely afraid of local anesthetic injection, and it is very difficult to give anesthesia to the such patient, to the length that the patient will say, doctor, you remove the tooth without anesthesia, I can bear that pain but I cannot bear the pain of the needle. So basically they're having this phobia. So if you identify a patient having odontophobia, the cause will fall into one of these five, and then all you need to do is identify the cause and then remove it using behavior management techniques. And in behavior management techniques, we have some psychological techniques and we have some pharmacological techniques where you have to sedate the patient, give some medicine to calm the patient, and then you can remove the phobia or remove the fear. So this we will learn in more detail when we talk about behavior management techniques, begins with the next lecture. So with this, we end this session on child psychology part 3, and I want you to take 5 minutes to recall all that you learned today, you learned in this particular section, and just broadly try to recall or recapitulate the main headings of today's presentation, so that it will help you to form that schema. If you remember from the last lecture, those small boxes in your brain where you can put the other information into the boxes, it becomes very easy to organize. So take 5 minutes to recall what we learned. We learned about the different factors affecting emotions. We learned the body mapping, that is the topographic mind, the different levels of mind, the different system of mind, and which was very useful for us to understand how people react. So apart from this, I want to end my session with a question for you, and the question is, can you measure fear and anxiety? Okay, can I measure fear and anxiety? How can I measure fear and anxiety? Because if I'm able to measure fear and anxiety, I may come up with some innovative techniques which I can use in my clinic, and I can measure my fear to find out if those techniques are working or not. So if there is a way to measure the fear or measure the anxiety, so what I want you all to do is, I want you to post the answer to this question: can we measure fear and anxiety? So it could be yes, and you can measure it using this, or the answer could be simply no, because of this factor. So I want you to go to the Google Classroom, which is already up and running with the title of Child Psychology, and go there and post a message for me to answer this question, so I understand that you have gone back and read something on your own to understand the situation. So with this, I end the session, and I hope that you all have learned the concept of child psychology, because this is the foundation for you to learn the behavior management techniques, which you are going to learn in the next lecture series of 3 lectures. And from there, you will be able to appreciate how you can get clinical work done quickly and more efficiently, because now you're able to manage the child, because you understand the psychology behind the particular problem. Maybe it is a fear or the anxiety, or it is just an anger issue, and you can use appropriate steps. Okay, so the picture that I've shown you is how people perceive us, that we are dentists with a drill in our hand, and our job is to drill, fill, and bill the patient. Okay, so that is how the patient think of us. So we have to come across these kind of patients and use our clinical judgment, our knowledge, to overcome the patient's fear and anxiety and phobias, and convert a bad patient into a good patient. So if you're able to do that, that means you have developed the skills of dentistry, of negotiation, of communication, which will prove very fruitful, not for pediatric dentistry, but later on in life, in adult dentistry, in your personal life, and forever. So with this, I stop, and I wish all of you a happy, not happy, I mean, have a good day and enjoy yourself. And I'll see you next time when I come back with another set of lecture series. So it's bye from me. Have a nice day.